Okay, we'll continue with lower GI tract disorders. So the first one we're going to talk about is celiac disease. When I was in school, we called it sprue. Celiac sprue was the full name. It's a malabsorption disorder. It usually starts in childhood. It has a genetic link, and it's a problem with intestinal enzymes, brush border enzymes. And what happens is gluten gets partially broken down by the various peptases in the stomach and the pancreas, but the final enzymatic breakdown from gliadin to absorption doesn't happen. And this substance has an effect on the intestinal villi and causes the intestinal villi to atrophy and causes malabsorption because you lose surface area. But it's not a malabsorption of gluten and the products of gluten. It's a malabsorption of everything because of the reaction to the improper digestion of gluten. And so because it's a global malabsorption, it can lead to malnutrition. It's often found in kids because often the first solid foods that are given is cereals, pablum, and things like that. So that's when it's found that the kids can't tolerate it. So setaria, so fatty stools, muscle wasting, failure to gain weight, irritability, and malaise. Something's wrong with this kid. It's diagnosed with blood tests, and then gluten-free diet is how it's treated. If there's no gluten intake, then the intestinal mucosa, because the intestinal mucosa, remember, it's constantly being replaced. It's a very harsh environment, and so you're constantly making new cells with microvilli on them. You're making new villi. Like, you're constantly replacing and refurbishing. And so the mucosa returns to normal as long as it's not being further irritated by more gluten. This is the true celiac disease. There are a lot of people that are gluten intolerant, and I think it's got more to do with some of the amino acids that are involved in gluten. Glutamate is named that because there's so much of it in gluten. And until fairly recently, it was the major source of glutamate was gluten and dairy products. But now we get glutamate in everything because it's used ubiquitously to enhance flavors, because monosodium glutamate, etc., enhances flavors. But glutamate is an excitatory neurotransmitter, and our body can only handle so much without overreacting to it. And glutamate is added to all low-fat foods. Anytime you see something that says low-fat, read high glutamate, because that's the only way the stuff becomes palatable. So it's a real problem that we're getting too much glutamate now. And I wonder whether this spate of gluten intolerance and dairy intolerance is because we're getting more than enough glutamate elsewhere in our diets, whereas 50 years ago we didn't. So that's not necessarily celiac disease. Okay? We'll just kind of leave it at that. Celiac's more a problem of reaction and toxicity to the walls of the mucosa of the intestine. Chronic inflammatory bowel disease is the new term that encompasses Crohn's and ulcerative colitis, because they're chronic, they're inflammatory, and they affect the bowels. So we don't really know what causes them. Again, genetics probably loads the gun and environment pulls the trigger. Crohn's disease seems to come on fairly early during adolescence. My son's best friend ended up with Crohn's disease. It's under control, but he has it. Ulcerative colitis comes on a little bit later, maybe 10 years later. There's a lot of similarities, but there's enough differences. So if we look at them, Crohn's disease tends to be the terminal ileum and into the colon, where ulcerative colitis is further along. It's in the colon and rectum. Crohn's disease is all the layers of the tube, and the lesions skip. There's areas of good tissue and then bad tissue and good tissue again. Ulcerative colitis is only in the mucosa, and the lesion tends to be continuous. If you have Crohn's, you have loose semi-formed stools, but in ulcerative colitis, you have really frequent watery stools with blood in them. Crohn's disease will end up with granulomas, basically granular scar tissue forming in the transmural layers. And they will erode and cause fistulas, so joining between loops can cause abscesses and that kind of thing, where neither of these things happen in ulcerative colitis because it doesn't go down through the other layers. Strictures are common because of the scar tissue, where they're not common in ulcerative colitis. Malabsorption is a problem because the blood vessels erode, and malabsorption is a big problem. Ulcerative colitis, because it's mostly in the colon, there's not a lot of absorption happens there. More happens in the small intestine. So this is not complete in any way, but it really indicates some of the differences. I like to think in my own head, and this is just from my own way of keeping this straight, I think of Crohn's disease a lot like psoriasis, with these patchy, skipped lesions that go down through multiple layers. It can cause granulomas and strictures and things like that. So Crohn's disease can be anywhere in the digestive tract, but it's usually the small intestine. They have these skip lesions. They get inflammation and fibrosis, can cause obstruction, impairs absorption of food, and you have high motility because the inflammation stimulates the motility. So it interferes with the digestion and absorption, and so people end up with malnutrition sort of things. There can be adhesions between loops, and fistulas can form. And we use steroidal anti-inflammatories, so glucocorticoids, prednisone. So we see these sorts of things. Ulcerative colitis usually starts in the rectum, and it's inflammatory. It's mucosa and submucosa, tissue destruction. If there's absorption problems, it's fluid and electrolytes. We can get toxic megacolon, but you have really a lot of diarrhea with blood and mucus and cramping. Just a picture. So, inflammatory bowel disease. So we use anti-inflammatory medications, anti-motility agents because we want to slow it down, nutritional supplements to make up for the malabsorptions, immunotherapeutic agents and antimicrobials, and remove the lesions, so ileostomy, colostomies, resections. Irritable bowel syndrome, and be careful, IBD is inflammatory bowel disease, irritable bowel syndrome is IBS. This is abnormal GI motility and secretion and hypersensitivity. We can have overgrowth of flora, food allergies. There seems to be psychosocial factors involved, but there's no definitive kind of diagnostic test. It's almost like when you've ruled out everything else, but you're still seeing these measurable signs, then they call it irritable bowel. Lower abdominal pain, diarrhea, or constipation, alternating with diarrhea. You base the diagnosis on history, signs and symptoms. They test for food allergies, but that's not necessarily going to bring back anything. You test for infections. It doesn't really mean anything if there is or if there isn't. It can still be IBS. And they really don't know how to cure it. So it's all about management and helping people through their episodes of it. It tends to be episodic as well. The appendix is a little bit of lymphatic tissue that's off the end of the cecum of the large intestine. The big thing is appendicitis, so you get obstruction of the lumen of the appendix, and fluids build up and microorganisms proliferate. The wall becomes inflamed and it becomes swollen and you get exudate. Can develop into ischemia and necrosis, and then if that happens, it'll burst and you can end up with a peritonitis because the bacteria and toxins escape into the surrounding. Sometimes it will form an abscess and then the pain will temporarily subside, but you're not out of the woods. You have to be very careful about infection and peritonitis around it. The blockage can cause necrosis and can be actually gangrenous. And if it ruptures and perforates, you can have life-threatening peritonitis. So what we do is remove the appendix and give lots of antimicrobial drugs. So the pain is at McBurney's point, halfway between the belly button, the umbilicus, and the AIS, the anterior, or the ASIS, the anterior superior iliac spine, on the hip. You get rebound tenderness there when it's inflamed. You push down, and then you get pain when the pressure is released. It then can rupture. The pain will decrease when it ruptures because now the pressure's off, but the contents spill into the peritoneal cavity, and then you get peritonitis as the infection spreads. It can be terrible. So you get this periumbilical pain at first, nausea, vomiting, right lower quadrant, rebound tenderness as it gets bad. After rupture, the pain goes away, then it comes back really severe. You get fever and leukocytosis, lots of inflammation. Your abdomen gets really stiff. You're losing blood, hypotension with tachycardia, compensating. Can be toxins, that kind of thing. It's life-threatening, and they do emergency surgeries for them. Diverticular disease, we've already touched on a couple of times. So a diverticulum is an outpouching, a herniation of the mucosa through the muscularis, anywhere, but this happens to be the colon. Diverticulosis is when you have diverticula. Diverticulitis is when the diverticula are inflamed. So anybody that has diverticulitis will have diverticulosis, but not all diverticulosis becomes diverticulitis. And it happens more in the colon because the house of the colon is missing most of the longitudinal smooth muscles. So the muscularis is much thinner, less developed there. And all of the fibers tend to run one way, which is easier for herniation. So you get this gap between the muscle layers. The weaker areas bulge. Usually it's asymptomatic, but if something gets caught in there, stasis, it leads to inflammation and infection. You get cramping and tenderness, nausea and vomiting. So if there's opportunistic infection, we need antimicrobials, but mostly we need dietary modifications. It's really important that people have a lot of fiber and they are passing things quickly, that poop doesn't stay there for very long. My wife has this, my neighbor has this, my mother had this, so I'm well aware of these acute diverticulitis symptoms. Colorectal cancer develops from polyps on the mucosa. And it tends to be from like the goblet cells. Catching it early is really important. It happens in older people. It runs in families. In my family, on both sides, we've had a history of colorectal cancer and multiple polyps. My uncle was told after a colonoscopy that they'd never seen so many polyps in one person and that none of them were cancerous. But his sister ended up dying of bowel cancer. A cousin of his died of bowel cancer. This is my mother's brother. My dad had bowel cancer. My dad's mother had bowel cancer. My dad's brother had bowel cancer. So I started getting colonoscopies when I was 40, every 3 years, to watch for it, because if you catch it early, it's pretty good prognosis. You want high fiber diets. Moves things through and doesn't irritate as much, especially if you have genetic predisposition for it. If you have ulcerative colitis, it can lead to this because of the dysplasia, metaplasia. Initial signs, changes in bowel habits, but people don't pay attention to that. Bleeding is a big thing, which is how we found my dad's. Fatigue, weight loss, anemia, especially bleeding. Right now, my mother-in-law's boyfriend has it, and he has to get blood transfusions every 3 weeks because he's got this slow, leaky blood loss. He's just turned 90, and so he's not going to undergo treatment. They say that he wouldn't make it through the treatment, so we'll see. I don't think he's long for this world because it's metastasized and gone to bone and stuff. So if you catch it early, you can do surgical removal. You can have radiation, chemotherapy, but usually a bowel resection. It can happen in a bunch of different places. Usually it's the sigmoid colon or the descending colon. It can lead to intestinal obstruction, but so can a lot of other things. So this is anything that's going to stop movement of intestinal context through. It happens in the small intestine more. This can be mechanical obstructions, tumors, adhesions, hernias, other things like that. It'll happen sometimes in kids that swallow those little strong magnets, and they can pin things together and cause torsion, that kind of thing. You can have functional obstructions from spinal cord injuries, paralytic ileitis, from electrolyte imbalances, things like that. When you have obstruction, gases and fluids and everything accumulate proximal to the blockage and distend the intestine. And you have really strong contractions then to try and push it through, literally. The pressure increases in the lumen and you get more secretions, and it will compress the veins in the walls that make absorption bad, and intestinal walls become edematous and ischemic. The pressure will back up. It leads to vomiting, which causes more loss of fluid and electrolytes, and alkalemia. So the intestinal wall becomes ischemic, as I just said, and can become necrotic. And if it's not dealt with, it can become gangrenous. Innervation will stop peristalsis, which will make things worse. Paralytic ileitis can happen even if that's not the main cause. The intestinal flora and fauna go crazy. Some have endotoxins, which speeds up necrosis, and you get leaky gut. If you get perforation of the necrotic segment, then you can get a peritonitis, and septic shock can be life-threatening. So it can happen following surgery, spinal shock, ischemia, pancreatitis, peritonitis, hypokalemia, toxemia, all kinds of things. You can have mechanical obstructions from adhesions, twists that constrict the hernias. The intestine can out-pocket through the hernia, umbilical hernia, inguinal hernia. Tumors, foreign bodies can cause it. Various diseases, chronic inflammatory conditions can cause histological changes. So if you have obstruction of the small intestine, you get colicky pain, and you stop getting sounds because the peristalsis ends. If it turns into paralytic, you have steady pain and the bowel sounds are absent. Vomiting and distension happens. It's a medical emergency. You can't last for very long without it, with the small intestine blocked. Large intestine is much more slowly. It's constipation. The pain is more mild. Anorexia, vomiting. So treatment of underlying cause. So oftentimes it's torsion, especially in older people. Fluid and electrolyte management. May need surgery. That kind of thing. So here's a list. You can read it. Peritonitis, we've touched on many times in the past little bit. And so this is inflammation of the peritoneal membranes. It can be from enzymes, it can be from urine leaking from ruptured bladders, perforated ulcers in the stomach, blood. Sometimes it can be endometriosis, bile from the ruptured gallbladder. Any foreign material in the peritoneal cavity can cause it. Gunshot wounds, things like that. Toxic shock. Bacterial is often from direct trauma, a ruptured appendix, that kind of thing. Abdominal surgery, sometimes foreign materials left in there, like sponges or gauzes, that kind of thing. Pelvic inflammatory disease, which we've talked about in women. Infection comes through the fallopian tube. Can all cause peritonitis. So it's generalized abdominal pain, severe, vomiting, abdominal distension because of inflammation, local tenderness at the site of the problem, dehydration and hypovolemia, low blood pressure. So then tachycardia to make up for the low blood pressure, leukocytosis, that kind of thing. So treatment really is look at the primary cause and try and remove it. If it's bacterial, antimicrobial drugs, maybe surgery, that kind of thing. So here's a whole bunch of things. Chemical peritonitis, bacterial, infection, inflammation. So that is it for the digestive disorders that we're going to talk about.